This number will tell you if your patient is about to die before any other vital sign. Let's talk about end-tidal CO2. So what is end-tidal CO2? Well, it's the amount of carbon dioxide measured at the end of exhalation. So it reflects two critical systems. It reflects ventilation and perfusion. If they're ventilating, CO2 can leave the lungs, and if they're perfusing, CO2 can be delivered from the tissues. So when either system starts failing, end-tidal CO2 shows it first. And unlike oxygen saturation, it's immediate, it's quick, there's absolutely no lag. That's why we call it the real-time shock monitor. So how would we use it during procedural sedation, maybe giving a narcotic, or even during transport? So it gives you an early warning sign that the patient is hypoventilating or even obstructing. The SATs can still be 100, but the end-tidal CO2 climbing and the waveform may start flattening is a really big sign. It's an early alarm that you need to be looking out for. So oxygen hides problems, whereas end-tidal CO2 reveals them. So let's talk about where CO2 really shines. Let's talk about CO2 during a code. Well, if end-tidal CO2 is less than 10 during CPR, that means your perfusion is trash. Good compression should give you at least 10 to 20. And if suddenly jumps up to 30, well, that means you probably have ROSC. So don't wait for a pulse check. End-tidal CO2 already told you what you need to know. So how would we use it during trauma, sepsis, or even shock? So low perfusion means that less CO2 is returning to the lungs. That means there's low end-tidal CO2. If the number is dropping without any change of ventilation, that means your perfusion is crashing. So you need to watch that patient. So end-tidal CO2 is really cool. One of the coolest things about it is actually the waveforms. So you can use the waveforms to even predict certain things. I had a patient once with really diminished breath sounds who was getting worse and worse throughout the ambulance ride. And I started noticing shark fin waveforms on the end-tidal, but I couldn't really hear wheezes because of the bumpy ambulance and also the fact that they were diminished. So I ended up treating with albuterol, and the patient felt 10 times better after I was done, just based on the end-tidal CO2. So let's talk about the different waveforms that we should see. Well, a normal end-tidal waveform has a quick upstroke, a flat plateau, and a quick downstroke. If you don't have that, there's probably something going on. Let's talk about bronchospasm, secretion, and obstruction, what that looks like. If your upstroke isn't flat, if it's like a scaled upstroke, and if your plateau doesn't stay flat, well, that should key you off to maybe there's something going on with either bronchospasm, secretions, or obstruction. And then if your end-tidal waveform either goes flat or just completely goes away, well, there's two options, well, three options. Either it's disconnected, which I hope it's not, or you've completely lost your airway, or your patient may have lost a pulse. So this end-tidal waveform is really important for you because it can tell you the exact moment that something has completely gone wrong with your patient. So yeah, end-tidal CO2 might just be a number, but if you're not utilizing it, you are not using the most important number, the most important waveform that we have in critical care medicine or in emergency medicine. If you're not using it, you're really flying blind. So please start using it, start getting familiarized with it. End-tidal is one of the coolest, most useful tools that we have on the back of an ambulance. Have a good day.